When a woman has breast cancer, not only does insurance cover the reconstruction, it also covers the opposite breast. So a breast augmentation on the non-cancer side and a reconstruction on the cancer side, and insurance has to cover both. And really nobody knows that.
So you can get several things done at once.
And that's the beauty of it, right? If you're going to get diagnosed with breast cancer, you may as well get something good out of this.
Millions of women are survivors of breast cancer, but many are not aware of options for breast reconstruction after mastectomy. Today, Dr. Tracy Cordray joins us. She's a plastic surgeon in Santa Monica specializing in breast reconstruction. And later in the show, she gives you options for body contouring if you need a little nip and tuck after massive weight loss from gastric bypass. Pleasure to have you here today, Dr. Cordray.
Thank you. Nice to meet you. Thanks for having me.
My pleasure. You know, I noticed there's a scene in the movies sometimes where the woman is a little embarrassed or ashamed or something, and she shows the scar. And I don't know if you've ever seen that moment that I'm talking about.
Sure.
I saw one with Kim Basinger and Charlize Theron. But I guess this is an option for women who don't want to have the scar. Is that?
Absolutely. And it's certainly an option for anyone who's had breast cancer of any kind, whether they've had a partial mastectomy, a complete mastectomy. And the unfortunate thing is, not every woman is offered these options. And so I'm trying to get the word out there that certainly every patient is a candidate and can undergo all of these operations.
So everyone who has the surgery can?
Absolutely. Anyone who has breast cancer. Sometimes it's better to wait until after treatments until after they've undergone other therapies and then have the reconstruction. But more often than not, we do it at the time of the mastectomy, which is called immediate reconstruction.
Oh, so at the time. At
the same time. So patients actually go to sleep with the breast and they wake up with the breast. And that's really great for a woman's psyche. You know, it's tough to be losing part of your femininity when you lose a breast due to cancer, this, you know, dreadful disease.
Well, you know, I was thinking about it earlier, and I hate to say it, but I was thinking of what an analogy might be for guys, and I thought, yeah, you know, that'd be pretty traumatic.
That would be
so,
really traumatic. Absolutely. So now you can see where I'm coming from. It's great when a woman goes to sleep with a breast and has her mastectomy, wakes up with a new breast. And quite frankly, sometimes they look better than the old one.
So what percentage of women have this done? I mean, it sounds like not.
Unfortunately, not enough. Right, not very many. I mean, I would think that in Southern California, certainly, it's very common for women to be offered breast reconstruction. After all, this is LA, right?
Right.
But across the nation, in the Midwest, in the Southeast, not that many patients are offered it. I can't give you an exact percentage, but certainly all plastic surgeons would agree, that it's not offered enough.
And why is that?
I think that the mastectomy surgeons sometimes just feel like they need to have the mastectomy, get their treatment, and if they don't recur in a year or something, you know, have recurrence, then to move forward. But beyond that, I think it's just a lack of knowledge.
But there's really no reason to wait medically, that it's like the survivability rates or recurrence rates or something?
Does not affect survivability or recurrence.
I see. Now, this is covered by insurance?
This is covered by insurance, actually by law. When a woman has breast cancer, not only does insurance cover the reconstruction, it also covers the opposite breast. If the opposite breast is clean without malignancy, it still covers maybe a lift, maybe an expansion, maybe a new implant on that side. So a breast augmentation on the non-cancer side and a reconstruction on the cancer side, and insurance has to cover both. And really nobody knows that. So.
Well, since you mentioned this is LA, and you do think of, you know, breast implants for other reasons than breast cancer, but sometimes too there's kind of a negative side to it. You know, you hear that things can go wrong or spill or leak or slip or whatever. You know more than I do about that. But is there a downside to something like this, the way that you may think of breast cancer?
Well, there are risks to every operation, right? Every single operation has a risk. But as far as comparing a cosmetic breast augmentation to a reconstruction with an implant, I would say really the only increased risk would be that If a breast has been radiated, which some patients have had radiation in the past or are going to get radiation, that then increases the risk of what's called capsular contracture, which is the capsule forms around the implant. And if it's radiated tissue, it has decreased oxygenation, decreased blood flow, and for whatever reason, I won't go into all the chemistry behind it, but the capsule that forms around the implant can become thick and therefore hard, and that's when the breast feels hard, and obviously a woman doesn't want to have a hard breast, right? Want it to be natural and soft. And so I would say that in a reconstruction patients, the risk of it becoming hard and getting capsular contracture is 30%, around 20 to 30%, depending on the study that you quote. And then in a breast augmentation patient, the risk is lower, like 8 to 10%. 8 to 10%. Yeah, so it's a little different.
And can something be done about it if it would happen?
Absolutely. Usually it does require another surgery, but it's an outpatient surgery, very easy on the body, very quick recovery, can have it on a Friday, go back to work on Monday. It's usually not that big of a deal, but you can just exchange the implant out for a new one, take out that scar tissue, and then you can switch it to a textured implant. You can do many things, but yes, there are certainly options to fix it.
So, if for someone who is has had a mastectomy or is facing that, what are the options what would you tell a patient who comes in and wants to know what the options are?
Okay, so basically what I would tell a patient who comes in with breast cancer, a new diagnosis of breast cancer, would be that the options range from using a foreign body, which is an implant, to just using 100% autologous tissue reconstruction. Autologous meaning coming from your own body, okay? So the one with the implant is, it's easier in the short term because it's a fairly quick surgery with a fairly quick recovery. Whereas the autologous tissue one, which is tissue from the woman's own body to reconstruct the breast, is a much longer surgery in the upfront and a longer recovery, maybe 6 weeks that someone might have to take off work. So it's a little more sacrifice up front. But in the long term, you don't have capsular contracture to worry about. You don't have to worry about, is my implant ruptured? Is it leaking? You don't have to worry about, can my boyfriend or husband feel it or whatever, because it feels so natural. It just feels like your own breast tissue.
So fewer side effects or risks?
Fewer side effects in the long term. But remember, up front, it's a longer surgery and more risks.
But insurance covers both of them fully?
Absolutely. Insurance covers both of them, yes. So for the implant reconstruction, I tell patients that they have to come in at the time of the mastectomy. We put in a tissue expander, which is a non-permanent implant. It is a device. It's non-permanent. We put it in maybe with 100 cc's of saline in it or so. You have to put it underneath the muscle. That's the pectoralis major muscle. And then 3 weeks after, once it's all healed, I start to inject it with saline and expand it up to the point where either it matches the other breast, or if it was a bilateral or double mastectomy, then we just decide how big does the woman want to be now. And then so we keep injecting saline weekly or bi-weekly until it gets to the size that we like. And that usually takes maybe 4 months. And then at that point, the patient has a quick outpatient surgery where we go in, we take the tissue expanders out, maybe do some cuts, some capsulotomy. It just means making a cut basically in the tissue that forms around the implant, and then put in nice new soft implants. Just regular silicone gel breast implants. So that's a permanent device. And then the patient is usually done, okay? If it was I'm sorry. Sometimes the patient is done, not always, because then you might have to create a nipple, because if the nipple was removed during the mastectomy.
Well, I'm sorry, that is an opportune moment to take away. We'll find out how you put the nipple back.
Okay.
Up next, more with Dr. Cordray. We'll be right back. And we are back with Dr. Tracy Cordray today talking about breast reconstruction after mastectomy. So you were talking about how they actually replaced the nipple.
Correct. So what's the most cutting edge technique now in the world of breast cancer surgery, i.e. mastectomy, is sparing the nipple, which we do at St. John's in Santa Monica in certain, if the patient is a candidate. So in certain patients, we can actually do a complete mastectomy, curing the patient of breast cancer, local disease, and leaving the nipple intact. So when I go in and put in an implant, it actually does just look like a breast augmentation, and that is really the best of both worlds. However, some patients are not a candidate to spare the nipple. That is being a nipple-sparing mastectomy. So if the patient needs a modified radical mastectomy where the nipple is going to be removed, then it's my job later, after they get an implant put in, to create a nipple. And I do that with like skin origami. You make these skin flaps, you like paper origami, except you're doing it with skin. And you create a column so it's a protruding nipple, and then later I tattoo it.
Tattoo it?
You tattoo it to match the color of the areola of the opposite natural nipple.
Well, even when you were talking about the breast reconstruction from body's own tissue, what part of where do they get the tissue from?
Right. So the other extreme would be to take tummy, fat, and skin from the lower abdomen. It's really a cosmetic tummy tuck. And a cosmetic tummy tuck...
So you can get several things done at once here.
And that's the beauty of it, right? If you're going to get diagnosed with breast cancer, you may as well get something good out of this. So, yes, so some women who have had a baby or two and they might want a cosmetic tummy tuck anyway, we take tummy fat and skin from the lower abdomen, sparing the muscle, which is a fairly new technique called a deep inferior epigastric perforator flap. It's a perforator flap for breast reconstruction, which is autologous tissue from the lower abdomen. Instead of discarding it, which you would do in a cosmetic tummy tuck, you save it and you bring it up here. You completely detach it from the body, okay? Then you bring it up to the breast cavity where the breast used to be. We dissect out blood vessels in the chest, okay? And then under a microscope, you have to sew artery to artery and vein to vein so that that tissue then gets reperfused. Because obviously it has to have circulation or it will just die and be dead fat. So we do microsurgery under a microscope, sewing the vessels back together. Then it gets perfused and it makes a very nice natural breast. Because really all it is your own tummy fat and skin. And sometimes, you know, you have some skin showing. It just depends on the patient. Again, if it was a nipple sparing mastectomy, then you wouldn't have any skin showing. It would just all be fat underneath the breast skin. So it looks very natural and really looks like the other side natural breast. It's a very nice match.
Well, when you mentioned, you know, some of the various options, what are the considerations, you know, when you explain to the patient what their options are, what are some things that might guide someone a certain direction? Or are there certain types of patients or age ranges or that sort of thing that something's better for them?
I would say number one would be if the patient has had radiation in the past. Don't forget that some people have had a breast cancer before. Unfortunately, it does recur. It can recur. So if a patient has had a lumpectomy, say back in 2005, and they got a partial mastectomy or lumpectomy, which is just where you go in, you take out only the cancer and get clean margins around it, but you leave the rest of the breast tissue intact. At that time, the patient would have received radiation therapy. You don't just get a lumpectomy or partial mastectomy without radiation for invasive cancer. So let's say the patient had breast cancer in 2005, got treated with a lumpectomy and radiation. Now she has a recurrence in 2009. Probably that's not a great candidate for implant reconstruction, just because of the radiation and the damage that it does to the local tissue. So that patient I would more so encourage to have autologous tissue reconstruction. Again, tissue from your own body, either from your lower abdomen, move it up to the breast, re-sew the blood vessels. The other option for that patient with radiation would be to swing a muscle around from the back called the latissimus dorsi muscle. You can swing that around to the front, put a small implant underneath it, and that also provides better blood flow to this radiated bed. The other criterion that I would that would help me make a decision of the approach to reconstruction would be whether the patient has breastosis. So ptosis is droopiness of the breast. So if a patient has a droopy breast, maybe older, maybe, you know, had a lot of babies and breastfed and still fairly young. But if a patient has breastosis or a droopy breast, they're not a great candidate for implant reconstruction. It's just hard to make it look good. I'm not saying they can't have it done. Certainly you can, but I think that they have a better, more superior outcome with autologous tissue reconstruction.
And, well, I know you said insurance covers most of this, but can you talk about, I mean, generally what you're talking for a procedure like this? I mean, is it...
What the cost is?
Yeah. Or I guess not the insurance company really about it, is that?
I mean, I don't make a fee for a certain procedure. There are actually codes for these things, and you just bill insurance companies for a certain CPT code, and healthcare is, you know, vastly in the news right now, but certainly, you know, Medicare would pay X and Aetna would pay triple X, and you know, yeah, exactly. So who knows? I can't give you an actual number.
Okay. We won't pin you down. Now, you mentioned the recurrence of breast cancer. So it is possible, though, that with any of these procedures that you could get it again, and what do you do with it?
Okay, so yes, when a patient presents with a new diagnosis of breast cancer, the approaches to that would be either a lumpectomy with radiation. We're talking invasive disease right now. I don't want to get too detailed in DCIS and other, forms of breast cancer, but in invasive disease, you basically have two options. You can do a lumpectomy with radiation or a mastectomy. And remember, the lumpectomy is just removing the cancer with getting clean margins of breast tissue around it, but basically leaving the breast intact. It's still going to be there. And then a mastectomy, obviously, is just removing all of the breast tissue.
So I didn't mean to interrupt. So nobody's ever gotten breast cancer from like a reconstructive breast or something like that?
Not due to the reconstruction, no. But if you have the lumpectomy with radiation, your recurrence rate is about 1% per year. So at 10 years, you have a 10% recurrence rate. At 20 years, you have a 20% recurrence rate. If you have a mastectomy, when you initially find out you have breast cancer, your recurrence rate, for the long term is 5%. So you're taking a little bit more of a risk with just doing the lumpectomy and radiation. Because remember, at 20 years, you have a 20% risk of recurrence. At 10 years, you have a 10% risk of recurrence. If you have a mastectomy, it's 5% or less even for the remainder of your life.
Up next, more with Dr. Tracy Cordray. Find out what to do if you need a little nip and tuck after gastric bypass surgery. We'll be right back. And we are back with Dr. Tracy Cordray today talking about breast reconstruction after mastectomy. Well, as I said at the top of the show, there are millions of survivors of breast cancer. How common is breast cancer among women?
So now, in 2009, actually 1 in 8 women are diagnosed with breast cancer.
1 in 8?
1 in 8, I know. It is pretty astonishing, absolutely. And then some backgrounds or ethnicities are at increased risk, one of them being Ashkenazi Jewish. So Ashkenazi Jewish women are at a much higher risk of developing breast cancer.
I'm sorry, can I ask, what is Ashkenazi? I know what Jewish is, but I don't know what Ashkenazi is. What is
I believe it's from Poland.
Oh, okay, a sector.
A sector, right, exactly.
Okay.
So those women actually should undergo what's called BRCA testing. It's a relatively new genetic test, which is just drawing some blood, and insurance covers this as well. So they can get tested to see if they're carrying the genetic mutation for breast cancer. There's the BRCA1 gene mutation, the BRCA2 gene mutation. That's the only ones we know of now. I'm sure that there are many others that exist, but currently in 2009, that's what we can test for. So anyone who actually has a positive family history, a mother, a maternal aunt, a sister that's had breast cancer, should probably consider BRCA genetic testing.
And what other groups also are at risk as far as ethnic groups?
Right, so really that's the only ethnic group that's known to have a higher incidence of breast cancer. However, African American women, when they are diagnosed with breast cancer, tend to have a worse outcome for whatever reason. I'm not exactly sure why that is, but it's just been shown in multiple studies that compared to other ethnic backgrounds, they don't have a higher incidence of breast cancer per se, but when they do get it, they tend to have a more aggressive cancer.
And so you said they don't really know why for that, and they don't know why for Ashkenazi Jewish, if I'm slaughtering that, but they don't know why.
No, not really why. I think, the Ashkenazi Jewish is more than likely a genetic mutation, so that would be a gene.
I see, okay. Now, I know it's not as common, but every once in a while I'll pick up the paper and read something about male breast cancer, but that's fairly rare.
It is fairly rare. 1% of all breast cancers occur in men, so it's not very common at all. However, it does occur. And when it does occur, the treatment is basically a mastectomy. It's not like you're going to go in and do a lumpectomy in a male breast, because there's not that much breast tissue there to begin with. The other thing is it's generally diagnosed at an early stage because there's not that much breast tissue. It's very superficial and palpable. You can pick it up easier on physical exam. So generally it's detected fairly early in its process and can just be treated with a mastectomy. and you can really barely tell, to tell you the truth. It requires no reconstruction.
No, I was going to ask, okay. And you've never done one.
You don't need me.
Okay. And the survivability rate is pretty high?
Very high. Very high, yes. Absolutely.
Well, it's fortunately encouraging news on that side
but
at least.
Certainly, if men have a strong family history, their mothers or grandmothers, or even if maybe their father or an uncle had a male breast cancer, for sure they should be tested.
But interesting. So even if just on the female side alone, then you should. Oh. Well, in addition to the breast reconstruction, you also work with patients who've had gastric bypass surgery.
Yes, I do.
And as I said at the beginning, there's a little nip and tuck, but there's a lot of things that need nipping and tucking. So what are you dealing with, and what do you do when you've got somebody who comes in who's had gastric bypass?
Right. So patients who have had gastric bypass lose a lot of their body weight. I mean, they can lose 100 pounds, 150 pounds, and they can show up at the plastic surgeon's office with a lot of excess, what I call empty skin. It's like it used to be filled with fat cells, and now that they have dropped to a tremendous amount of weight, they have all of this excess skin. It's just kind of hanging there.
I've seen
it's very
some pictures
high,
like
it's
that,
hard,
yeah.
It's difficult to camouflage it in clothing.
And that'll never go away naturally?
It'll never go away, not all that excess skin.
And even if you lost the weight gradually, even if you hadn't had gastric bypass, even then you could still end up with...
If it was a massive amount. If it's massive weight loss, say maybe more than 50 pounds, more than likely the skin is not going to be quite elastic enough to go back to being tight and flat. So if you lose more than 50 pounds, I would say you're going to have some sort of nip and tuck, as we like to say. Yes.
So what kinds of procedures then do you do on these patients?
Okay, so initially when a patient presents having lost 100 pounds, let's say, they have all of this excess skin hanging down. Quite honestly, the first thing that bothers them is the abdominal area. Pants can't fit right, can't wear a belt, don't want to tuck in my shirt because it looks ugly. So we generally start with either just a tummy tuck, which is an abdominoplasty, with or without a hernia repair, because a lot of times if they've had the open gastric bypass with a vertical incision in the abdomen, a lot of times they have a hernia for, just from the prior surgery. So with or without a hernia repair, we do the tummy tuck or abdominoplasty. Now sometimes the buttock even becomes saggy. Who likes a saggy butt, right?
That's right. Yeah.
So we'll sometimes do a belt lipectomy, which is basically a circumferential abdominoplasty. It's a butt lift, right, exactly. So we make an incision all the way around the patient's body and excise all that skin and close them up. And it sounds really easy, but it takes a long time. It takes a long time, and you have
How long
to
are you
be very
talking?
careful.
Hours?
Yeah, I would say for a belt lipectomy, because remember you have to turn the patient while the patient is asleep, and we have to be very careful about that. So that surgery alone is probably 6 hours, maybe longer, 7, 8, between 6 and 8 hours just for that operation. So I would say that's the first operation that's done when someone has lost, I'm using the example of 100 pounds. So the next operation to be done, once they heal from that, and again, you need to, I spread these operations out because they need several of them. Spread them out by at least 3 months.
3 months.
Yeah, just let them heal, get back to eating normal diet, because right after surgery, patients never feel like eating regularly and eating good protein. So,
and is there a risk, like after any surgery, when you do something like this, as far as infection or anything, or is it fairly routine, or is it?
It's not. I would say it's not routine because these patients generally have a malabsorption problem, at least a little. I mean, if they've had gastric bypass, they have some malabsorption. So you have to really check their nutritional parameters. We check like a prealbumin and an albumin in their blood work before the surgery, and that's not a normal thing that you would do if you were coming in and going to have cosmetic surgery. So you do think more nutritional deficits in gastric bypass patients. So if you have low nutrition or low values that we check, then you have to postpone the surgery until we can get it normalized. Otherwise, they won't heal. You have to have good protein in your blood to heal wounds.
Well, I'm sorry, we're running out of time really quickly, but but are there additional stages then that you would do?
There are definitely additional stages. So following the belt lipectomy or just the abdominoplasty, usually the next operation would be a combination operation of a mastectomy, which is a breast lift, excising all the excess skin around the breast, and then the brachioplasty, which generally you put the scar under here so that when the arm is down by the body, you can't see the scar. But a lot of people have this, the bat wing. It's this excess skin that hangs down. And you do have to make an incision here. You can do a little liposuction in addition, but you have to excise the skin here. So that would be the second operation, combination mastectomy brachioplasty. The next one, again, 3 or 4 months later after they've healed. Then you do the medial thigh-plasty. Patients get a lot of excess skin hanging on the thighs, okay? And then following that, the last operation would be a facelift. Because don't forget that even just normal aging process, you lose fat in the face. And certainly if someone loses 100 pounds, believe me, they're going to lose a lot of fat in their face. And then they just look old. They just look really old and sad. And so the last I didn't realize that, so you actually... The last approach we do for these massive weight loss patients is to do a facelift.
And again, so finally, this is over months, so by the time you do all of these, you're talking... It probably
takes a year. You could, if the patient is really good about, you know, getting their diet back to normal, getting back to exercise, you know, 6 weeks later, and just following up with their appointments regularly, you could feasibly get it done within a year or maybe, you know, 14 months.
Well, and one last quick question, and then we've got to go, unfortunately. Is there any way you can take that excess skin and like transplant it for the breast reconstruction patients, or it wouldn't work going person to person like a skin? You couldn't do it person to person because then the patient would have to be on immunosuppressants, just like someone who gets a kidney transplant. We haven't really made it quite that far. I don't know what it will be like in, you know. Because I was thinking of all that extra skin out there, which is right about the visual.
But what you can't, they are doing studies at USC Burn Unit where they take this excess skin and they do studies on it for epithelial cells that they might be able to use in burn victims.
Thank you very much, Dr. Tracy Cordray, plastic surgeon in Santa Monica. Thanks everybody for watching. We'll see you next time.